Hello and good evening, everyone. So it gives me immense pleasure to welcome all of you for this new initiative which we have taken as a body of SEAASM, which is Southeast Asian Society of Sleep Medicine. So we will have this webinars once a month, mostly on Tuesdays from 8 to 9 p.m. And we'll have topics which are very close to respiratory medicine, that is on the sleep. And we have these webinars where national as well as international faculty will be joining to us. So today our first talk is going to be about the sleep architecture, and for that we have our esteemed colleague, and plus along with me we have Dr. Rajesh Swarnakar, who is going to give us a brief message about this particular initiative which is been done by SEAASM. So sleep medicine, we all are aware that it is growing, and we all should be diving deeper and deeper into this and just not scratching the surface what we are doing up till now. So I will just like to request Dr. Rajesh Varnakar to say a few words about this particular initiative. Thank you.
Hello, my dear friends. A warm welcome, and of course, respected faculty, distinguished speakers, panelists, my dear colleagues, and all the members of Southeast Asian Academy of Sleep Medicine. It is both a privilege and a matter of deep personal satisfaction for me as past president and now patron of SEAASM to inaugurate the first webinar in the series The Science of Sleep, and the theme chosen today of understanding the sleep architecture, which is both fundamental and forward looking. Sleep, as you know, all friends, that is no longer a passive state of rest. It is a dynamic, highly regulated biological process that influences nearly every system of the human body. As sleep medicine clinicians and researchers, our responsibility extends beyond diagnosing just sleep disorders. We must actually deepen our understanding of sleep physiology, translate emerging evidence into clinical practice, and build a regional collaboration in sleep medicine. And initiatives actually like this contribute to basically academic excellence. It also contributes to what you call capacity building and also dissemination of contemporary knowledge across our country and hopefully across Southeast Asia too. So I congratulate Dr. Shivani Swami and Dr. Jayaraman and our entire CSM team, which is currently being led by Dr. Mahavi Modi, and also our esteemed panelists and speakers who would be actually contributing their expertise to this important series on sleep medicine. I also acknowledge the continued support that actually makes such an academic engagement possible. So, with great pride and optimism for the future of sleep medicine in our region, I formally inaugurate this first CSM webinar in series of such webinars that will happen in near future, and hope that we all benefit immensely interacting with each other to ultimately benefit our patients. Thank you and wish all the success in this academic endeavor.
Thank you so much, sir. I mean, that was such a welcoming for all of us. So without wasting much of your time, I will like to introduce our today's speaker, who's none other than our Dr. Jairaman. He had done a fantastic conference of SEAASM last year in Chennai. And I look forward for his continued support because he's a person with vision, and he is doing level 1, level 2 sleep studies, and his knowledge about this sleep is definitely something which we all are looking forward to listen to him. Just one thing which I will like to make clear is that sometimes we don't like to read more about physiology and our all respiratory health. If you want to see a holistic approach towards our patients, I think something which is very important is to understand the physiology of sleep. Once we develop more and more sleep health, definitely our patients of, let it be airways, let it be even interstitial lung disease, cough, asthmatic patients. So all these patients, they are going to benefit, and it is not only going to be only for the sleep apnea patients. So, Dr. Jayaraman, please welcome, and you can start with your presentation. Thank you so much.
Thank you, President Dr. Mahavir Modi, for the wonderful intro about the CSM as well as me. So I'll take it to forward. Thank you very much, Southeast Asian Academy of Sleep Medicine. It's a wonderful organization. They way back in 2013 started this association. I thank our founder president of our CSM, Dr. Kimanshu Gar, and the patron and the past president and Dr. Rajesh Sonakar, the immediate past president, Dr. Pratibha Dogra ma'am, and the president, Dr. Mahavir Modi, and the dynamic secretary, Dr. Shivani Swami, and all the leaders behind the SEAASM, Southeast Asian Academy of Sleep Medicine, Dr. Ravi Doshi, Dr. Gopal Rawal, vice president, and Dr. BP Singh, Dr. Mayank Saxena, Dr. Arjun, Dr. Amita Nene, Rajadar, and a lot of leaders behind the CSM working hard. So we'll be starting the first webinar from today onwards with the blessings of our patron and the past president, Dr. Rajesh Sonakar sir, and with the introductory opening remarks by our president, Dr. Mahavir Modi. So with that, I'll be, I'll introduce the panelists of today's important first webinar of Southeast Asian Academy of Sleep Medicine. So may I introduce the panelists now. May I introduce and welcome Dr. Ravi Doshi, consultant chest physician working in the Kogila Ben Dhirubhai Hospital, Indore. So Ravi is the ex-organizing secretary of SEAASM 2024. So wonderfully organized 6th International Conference on Sleep Disorders. It's a lovely city, wonderful city, the cleanest city of Indore. And Ravi Doshi is the governing council member of Indian Chest Society and the leader of Chest Council of India, one of the backbone of Chest Council of India, and very good orator, very good clinician, academician. Welcome, Ravi, for this prestigious SEAASM first webinar. May I introduce and welcome Dr. Deepti Bhatve, MD Respiratory Medicine, Senior Consultant working in Leelavati Hospital, Mumbai. Dr. Deepti is the Director of Ojas Hospital and Sleep Center in Dombivli. He's a so many fellowships. Yes, fellowship in Pulmonary Critical Care from Sayan Hospital, fellowship in Sleep Medicine from the ISDA, Indian Sleep Disorder Association, and he has a European Diploma in Sleep Medicine. So welcome, Dr. Deepti, for this prestigious CSM first webinar.
Thank you, sir.
Last but not the least, may I introduce and welcome Dr. Dilbagh Singh, consultant pulmonologist, critical care and sleep medicine specialist, Amandeep Medicity Hospital, Amritsar, Punjab. Dr. Dilbagh finished MBBS from PIMS Jalandhar and the MD Pulmonary Medicine from the Government Medical College, Amritsar, and underwent under DNB, passed out DNB, and he has MRCP, European Diploma in Adult Respiratory Medicine, fellowship in Sleep Medicine, and he passed out the International Sleep Disorder Specialist WS examinations from the World Sleep Society, and fellow in International Pulmonology and Critical Care and Mechanical Ventilation, and membership in various forums and his national and international faculty. So welcome, Dr. Dilbagh Singh, for this prestigious first CSM webinar. So we'll be starting from now with all the blessings of our leaders. So with that, the flow of the event, I'll give the 15 to 20 minutes talk, followed by we have a panel discussion. I welcome all the delegates. So please post your questions pertaining to the sleep science, the architecture of the sleep. So we'll have every monthly webinar. We'll update periodically. Stay tuned. So I'll be sharing my screen. I'll be talking about the science of sleep. 15 to 20 minutes, then we'll have a discussion on the basics of physiological sleep, etc. Is my slide is visible? Deepti, Mahavir?
Yes, sir, it is visible.
Yes. Okay. So today's topic is the science of sleep, understanding sleep architecture. The science of sleep, understanding sleep architecture. This is the topic today we'll be discussing now. A good night's sleep is often the first thing sacrificed as our schedules fill up with the commitments. Yes, this is the important thing. We have sleep deprived, and voluntarily we cut short the sleep timing, etc. So this is the basic about the history of sleep. Ancient Indian sages, Egyptians, Greeks, and Romans have all described the sleep in various ways, including the naming the gods who brought dreams to the sleepers. Not much progress made in further understanding until early 1900s. In 1925, Nathaniel Kleitman discovered the existence of rapid eye movement sleep and went on to study sleep and wakefulness and the effects of sleep deprivation. In 1959, a crucial distinction was made between the REM and non-REM sleep by Michael Jowett. So this is the first sleeping pill in the year of 1903 discovered. So it became one of the most abused drugs in US within 30 years. So barbital, barbituric acid. So by definition, what is sleep? Sleep is a dynamic and regulated set of behavioral and physiological states during which many processes vital to health and well-being takes place. Why is sleep important? People who sleep more than 7 hours are healthier and live longer than people who sleep less than 7 hours a day. Unfortunately, fewer than 2/3 of women actually get the much sleep each night. So what are the benefits of sleep? So sleep benefits are, it allows cells to heal. It boosts up immune system, rests the heart and cardiovascular system. The earliest and the largest effect of sleep deprivation is on the brain. So a lot of brain changes if we have a sleep deprived. So the changes in sleep in different body systems. There are sleep affecting various systems here. You can see central nervous system effects are increased parasympathetic tone and decreased sympathetic tone. If you take the cardiovascular impact, so decrease in heart rate and the cardiac output with an associated 5 to 20% fall in blood pressure. Coming to the respiratory system, ventilation is decreased mainly due to the decrease in tidal volume, decrease in ventilatory response to both hypoxia and hypercapnia. Upper airways narrows as tone decreases. This is the main mechanism we found in the disorders called the sleep apnea, the second common disorders we come across in our practice. Gastrointestinal system, decreased salivation, gastric acid production, and gastric emptying. Endocrine, many hormones show increased secretion during sleep, including a growth hormone. Renal, decreased renal blood flow and decreased in the urine production. What are the sleep characteristics, regulation, and measurement? How to measure the sleep? Sleep is not a passive condition. The brain and the body are highly active during this particular behavioral state. Sleep can be characterized by a prototypical posture, usually recumbency, an increased arousal threshold with a reduced responsiveness to external stimuli, and a loss of consciousness. Sleep is regulated homeostatically, meaning that sleep increases in duration and intensity after a prolonged period without sleep. In addition to this homeostatic component, a second process that is independent from prior wakefulness modulates the timing of sleep, namely the circadian system. This system is responsible for imposing and synchronizing a close to 24-hour rhythm on several behaviors and body functions, including the propensity to sleep or be awake along the 24-hour sleep-wake cycle. This is the brain structures which involves wakefulness and sleep. You can see here the hypothalamus and the midbrain, mainly the pons and medulla, and the reticular activating system. So are the responsible for the wake system. And coming to the sleep system here, there is a lot of nuclei, the preoptic nuclei and the raphe, all the structures which involves the sleep. It induces sleep. The various hormones and chemicals. So this is the important thing. You can see here the hypocretin orexin theory here. So in the case of the waking state, so balance is shifted towards a greater activity in wake promoting system, mainly the norepinephrine, histamine, serotonin during the wakefulness state. In the case of sleep, the balance shifted towards the greater activity in the sleep promoting system, mainly the chemical released from the brain centers, the adenosine, GABA, galanin, and melatonin, which induces the sleep. So any imbalance in this, which leads to a lot of sleep disorders. So late to bed, we used to say early to bed, early to rise. So these things which complicate a lot of system complications, mainly the increased REM sleep, which leads to higher heart rate and the higher BP, and this slow wave sleep, decrease in slow wave sleep, which leads to lower heart rate and the lower the BP. So which are all things which leads to a lot of changes in the system, which leads to increased feeling of fatigue, increased sedentary behavior, which increased risk of the type 2 diabetes and cardiovascular system and obesity. And the suppressed ghrelin peak, which leads to increased advanced glycation end product, which leads to endothelial damage, which causes a lot of cardiovascular and other thrombotic events. The unused cortisol peak, which leads to SNS activation, and the prolonged stress exposure. That's the growth hormone release, the increase in beta levels of amyloid, which leads to increased risk of dementia, and decrease in growth hormone release, which leads to decreased cell repair, decrease in bone building, decrease in regeneration, decreased fat burning, decreased learned body mass, which leads to a lot of complications, which may contribute to the chronic diseases. So there are three important sleep. This is one is the quantity. So other one is the quality and timing. So quality matters than quantity of sleep. So this is the stages of sleep. You can see very clearly. It's an awake stage followed by N1, non-rapid eye movement, and N2, and the N3 stages, and N4. But nowadays we see only the N4, 1, 2, 3 only. You can see here the REM stages, the later part of the sleep. Early morning, it gradually increases. So this is a normal physiological phenomenon for the stages of the sleep. What is coming to the physiology of sleep? Sleep itself is not a homogeneous process. There are two existing fundamental distinct types of sleep, or a rapid eye movement sleep, which is associated with the active dreaming. Non-rapid eye movement sleep. It switches between the NREM and REM sleep appears to be controlled by a reciprocal inhibition between the monoaminergic neurons and a specific subset of cholinergic neurons within the brainstem. So a lot of the neurochemicals, so which is responsible for the sleep and is responsible for the wake systems. The normal sleep pattern, if you take the stages of sleep, stage 1, stage 2, and stage 3 or 4, which comes under the non-REM sleep, which caters the 75 to 80% of the sleep. So in the stage 1, body starts to relax and falling asleep. So the stage, the component of sleep is 3 to 8%. In stage 2, the brain slows stable and light sleep, which is the 45 to 55% caters the entire sleep cycle. In stage 3 or 4, the body and tissue restoration and deep restorative sleep takes place. It caters 15 to 20% of the sleep stages. And we have a REM sleep. Learning and memory consolidation, dreaming of sleep is an important event, takes place during the REM stage of sleep. It caters the 20%. So REM takes place 20 to 25% in the sleep stages, and non-REM 75 to 80%. So coming to the sleep architecture, in a case of non-REM sleep, so we have a N1, N2, N3. N1, the transitional stage from wakefulness to sleep. So brain and body begin to relax, muscle jerking, twitching fairly common, easily aroused. Most people spend just a few minutes in stage 1. Stage 2, that is the N2 stage, is characterized by follow stage 1, breathing and heart rate slow down and become regular as the body further relaxes. Stage N2 lasts between 10 to 25 minutes, so 50% of total sleep time. N3, also known as a deep sleep or slow wave sleep, so deepest lowers the heart rate, BP, and respiratory rate. Its entry is a restorative biochemical process occur, so very difficult to arouse, no noticeable eye. It lasts 20 to 40 minutes and 20%, 25% of total sleep time. So this is called the sleep architecture, the stage wise. And this is the wave pattern. You can see the non-REM stage 1, characterized by the light sleep, transition from wakefulness, so hypnic, jets, hypnagogic hallucination, low amplitude, the wave pattern. This is important characteristics in the wave pattern. You can see here NREM stage very clearly characterized by the LMF wave pattern, which is the characteristic of the NREM stage 1. And in NREM stage 2, you can see very characteristically sleep spindles and K complex. This is a deeper sleep started. LAMF, that is a low amplitude mixed frequencies waves in the form of 11 to 16 hertz. You can see the K complexes in stage 2. And in this stage, memory consolidation links and inside the deep sleep. So N3 sleep or the slow wave sleep is a very important sleep. So NREM stage 3, the slow wave sleep, its appearance is a short-tooth pattern. You can see very clearly this is the restorative form of sleep in the N3. Coming to REM sleep, you can see here the low amplitude, the mixed frequencies of waves here, and the rapid movement dreaming. Brain activity resembles the wakefulness and the hypertonic state. So these are all the characteristic findings in the case of N1, N2, N3, and REM. The stage-wise, you can see the wave pattern very classically. So the importance of slow wave sleep, NREM 3. Slow wave sleep, which leads to it's considered as the most restorative period of sleep. Healthy adults spend 20% of sleep time in slow wave sleep, mostly occurs in the first half of sleep. So during the slow wave sleep, we can see increased vagal tone and decreased sympathetic activity, decreased heart rate and blood pressure, and decreased cardiac workload, and decreases the vasoconstrictive sympathetic activity. This is the importance of the non-REM 3 stages. Coming to the REM sleep. REM sleep architecture, the most dreams take place during this stage. It occurs roughly every 90 minutes. So progressively increases in duration throughout the night, occurs after stage 3 in the first part of the night, and sometimes after the stage N2 as the sleep progresses. So the first cycle can last up to 10 minutes and progressing up to 25 minutes. It accounts for the REM sleep or REM sleep accounts for 20 to 25% of the total sleep time. Sleep measurements, how to measure the sleep. PSG, polysomnography, is a gold standard for objectively measuring sleep in the laboratory. The sleeping brain shows a characteristic pattern of activation which can be measured by electroencephalography. So together with the measurements of eye movements, electrooculography, EOG, and muscle activity, electromyography, EMG, and the EEG is used to discriminate between the different stages of sleep. So actigraphy is one of the important measurement of the normal sleep architecture. Actigraphy is a common method for recording over periods of multiple days or weeks, employs an activity monitoring device usually worn on the wrist. So we have a lot of the to watch available, and we can see whether our sleep pattern is normal or not. This is one of the screening modalities that estimates basic sleep parameters such as the sleep duration, sleep onset latency, and the sleep fragmentation. So actigraphy is practical for long-term recordings in the natural environment and provides an estimate of habitual sleep duration and day-to-day variability of various sleep parameters. So the actigraphic watch and all nowadays a lot of personnel using for the sleep pattern. They can assess whether sleeping normal or not. This is one of the important screening tool we can measure ourselves, subjective measurement, and objectively we can see all the parameters. So hypnogram. The hypnogram is a convenient method of graphically displaying the organization of the sleep during the nighttime. So each stage of sleep is characterized by a level on the vertical axis of the graph with the time of night on the horizontal axis. REM sleep is often highlighted with a dark bar. You can see here the later part of the night, the REM sleep is more predominantly in the later part of the sleep. This is the sleep stages. You can see very clearly here. In a case of alert wakefulness, you can see the beta waves in the EEG pattern in a polysomnography. Beta waves is fast with many waves of more than 30 cycles per second, characterized by the low voltage random pattern with a few rhythmic components. The relaxed wakefulness stage is characterized with the alpha waves. You can see it 8 to 13 cycles per second. So low voltage again, rhythmic alpha with occasional burst of alertness pattern. N1 characterized by the theta. So the brain waves occurs mainly 3 to 7 cycles per second. So theta wave interspersed with a brief periods of alpha waves. N2, theta with the sleep spindles and K complexes, one of the characteristic finding, 12 to 14, lasting more than 0.5 seconds, isolated, slow, and high amplitude waves. So it characteristic of the at least one sleep spindle or K complex per 30 seconds on N1 background. So coming to the N3, slow wave sleep, it's a characteristic of the delta wave. We can identify the EEG pattern and the duration of this wave is less than 4 cycles per minute, and it characterized by the high amplitude and low wave pattern. So REM sleep, so type is N1 pattern with the short tooth waves and low voltage, random fast. Eyes move, the automatic system is activated. Respiratory and cardiac irregularities are more common in this REM sleep. Sleep and heart rate. In a normal sleep, the heart rate drops during the NREM sleep stages and then picks back up as you prepare to wake up. Oversleep, including abrupt awakenings, can generate a short uptick in heart rate. Research has also found that people with no sleeping problems are more likely to complain of an irregular heartbeat. So sleep and blood pressure, during normal healthy sleep, blood pressure drops by around 10 to 20%. This is known as nocturnal dipping, and this highlights its role in cardiovascular health. Poor sleep, whether from lack of sleep or sleep disruptions, is associated with the non-dipping, meaning that a person's blood pressure does not down at night. So studies have found that elevated nighttime blood pressure is tied to overall hypertension, high BP. So the lot of relations between the RTA, road traffic accident, and sleepiness, you can see one of the common association. So sleep deprivation, which leads to a lot of problems in the road traffic accidents and all. So motor vehicle accidents are very common in the early morning hours. So our past president and our patron, Dr. Sonakar sir, so we have given the memorandum of understanding and the request to the central minister for the road transport and highways, Mr. Nitin Gadkari, about the importance of the OAC assessment among the drivers on Indian highway, because the RT is very common in the early morning hours, mainly the truck drivers. Those who are not screened properly, so accident are very, very common, high mortality. So we requested to form all the regulations to the high-tech drivers through the official ministry. So we are awaiting to get the results from the central minister. So sleep disorders, the sleep physiology is very, very important to understand the sleep disorders. So various kinds of sleep disorders as per the International Classification of Sleep Disorder 3. So the common is the insomnias, and next is the sleep-related breathing disorders, and central disorders of hypersomnolence and parasomnias are very common. Sleep-related movement disorders, this all comes under the neuro perspective, and circadian rhythm sleep disorders. So the lot of manifestations. So further webinar, we'll discuss in detail about the sleep disorders. The key messages from this sleep architecture and the sleep physiology. Healthy and disturbed sleep both influence the quality of life. The disturbed sleep has a significant impact on other conditions. The subjective complaint can be classified into insomnia, insomnia, increased daytime sleepiness, and abnormal behavior during sleep. Treatment should address any underlying conditions and not primarily based on the use of sleeping pills. So according to the chemistry, alcohol is a solution. There are 5 tips for good sleep. The bedroom should be a quiet space reserved for sleeping. Regular habits of going to bed and falling asleep improve sleep. Keeping a regular sleep schedule improves sleep. Alcohol is not a suitable sleep aid. In practice, we are seeing a lot of patients, sir, I'm taking alcohol, and sleep is very nice and all. But later effect and lot of adverse reactions of the alcohol, relaxation exercise help to switch to sleep. So with that, I conclude my talk. Thank you very much for your patient listening. I welcome to join, save the date for our sleep summit to commemorate the World Sleep Day. SEAASM is doing a lot of activities. I request all the members and all the delegates kindly save the date of our 8th International Conference on Sleep Disorders at Ahmedabad on 21st to 23rd August 2026. So kindly join. With that, I conclude my talk. Thank you very much. I request all the delegates kindly post your question pertaining to the physiology of sleep and the sleep architecture and the science behind the sleep. So with that, I conclude. We'll start the panel discussions. I'll stop share my screen. Welcome all the panelists. We'll have a panel discussion and I request the delegates, you post the questions, we'll take accordingly. May I request Dr. Ravi Doshi to start with your first discussion about the science of sleep. So, brief question to Dr. Ravi Doshi. So, what is sleep architecture and how to measure the sleep? Over to Ravi Doshi.
Thank you, sir. First of all, I would like to begin by thanking SEAASM for giving this opportunity and for having this great academic discussion to all the office bearers. And you in particular, Dr. Jaraman, sir, you gave a very beautiful and lucid presentation just now. Well, sir, sleep architecture, the main topic of today's discussion is basically when we talk about the structural organization of sleep. Sleep architecture means mapping the cyclical patterns of non-REM, dividing them into N1, N2, N3, and REM throughout the night. Usually, in most, if it is a proper sleep, 4 to 5 cycles of nearly 90 to 110 minutes will happen. When, as and as the sleep progresses, REM duration progressively increases as and as late night or early morning approaches. Then non-REM comprises 80% of it. You beautifully illustrated in your slides that N1 is light sleep, in which there is transition from wake, and nearly 5% of all sleep is N1. N2 is light sleep, where there is nearly 50% of all sleep is spent in N2, mostly theta waves will be there. The important point is there will be a normal heart rate, normal respiratory rate. This is the time when the body actually starts to take rest and the core body temperature starts to fall. Then you have the N3 sleep, which is deep sleep or restorative sleep. This is the sleep where actually growth hormone releases, and this is the crux of all sleep, when we are actually restoration happens and sleep consolidation takes place. Followed by this, we have the REM sleep, which comprises nearly 25% of all sleep. And it is that position whereby there is an activated brain in a paralyzed body. Dreaming happens, and we can divide it into tonic and phasic, although that is mostly for a research purpose. But usually, clinically, 25% of all sleep comprises of REM sleep, sir.
Ravi Doshi. So, sleep architecture divides into non-REM and REM. Non-REM, N1, N2, N3. The light sleep, mainly in N1 and N2. N3 is a deep sleep. And REM sleep stages caters the 20 to 25% of sleep stages. REM sleep is important for the active dreaming and the other hypertonia of muscles. Thank you, Ravi sir, for the wonderful answers for the sleep architecture. How to measure the sleep? Measurement of the sleep, quality of how to measure.
Sir, this is to me only, no, sir? Yeah.
So I'll come to the next two. May I ask question to Dr. Deepti?
Yeah.
Yes,
So, change of sleep architecture across lifespan. So, starting from the geriatric, the entire lifespan. So, what is your take on this sleep architecture change in the lifespan?
Yeah, so generally, if I say in simple words, so your age is inversely proportional to your duration of the sleep, because as your age advances, the duration, your sleep efficiency, the total sleep time, and duration of sleep in every sleep stage starts declining. Like at the newborn, they don't have till 3 months of the age. It is divided into active sleep, which correlates with the REM sleep, and it is uh, um, deep sleep, which correlates with your NREM sleep. Then after the 3 months of the age, or at the 3 months of the age, melatonin starts releasing, and then starts setting your circadian rhythm. And then the minimum duration of the sleep is generally 14 to 16 hours per day. Now this continues till 1 year of age. From 2 years of age again, but yeah, there is one thing: at the newborn there is highest amount the REM sleep. The sleep starts with the REM onset. When they enters into the 3 months, then the sleep starts with the NREM, and they have distribution of the REM and NREM sleep. Then at the age of from 2 to 9 years of age, the sleep again declines by 2 hours. The total sleep duration is around 11 to 13 hours till the 2 to 10 years. But there is one funny thing: at the age of 6 to 7 years, the children start having their own preferences, whether they want to be night owls or early risers. They start getting their preferences at the age of 6 to 7 months. Then the most difficult part of the sleep which starts is the adolescent, 11 to 18 years, where the puberty hits, and because of this hormonal changes they have lot of difference in the sleep. So here the N2 sleep reduces, and they have the reduction in the N2 sleep. So what the data says ki there is 2% reduction in the slow wave sleep per decade across the lifespan. So at the age of 10 to 18 years, the total duration of the sleep is around 9 to 10 hours. Then in adolescent, it again reduces to around 9 to 11 hours. Then after 18 years, when they become adult, the total duration of time again reduces to 7 to 9 hours per day. But once they become more than 60 years, again the sleep duration that again reduces to 5 to 6 years. Like they go to sleep 1 hour late and they get up 1 hour early as per their adult duration of sleep. So there is 36% reduction in the total sleep time compared to their 5 years of age after 60 years of age.
Yes. So the sleep architecture changes from the newborn to the geriatric age of the 80, 90. It varies from the longer duration of sleep to start with, and the lesser duration once you age advances. This is normal and physiological architecture of the sleep. Thank you, Deepthi. And going to Dr. Dilbag Singh. Dilbag Singh. So, what truly defines good sleep architecture? Is it a stage proposition, continuity, or cyclic pattern? So, what is your take on this?
Thank you so much for the question, sir. That normal sleep cycle is around 90 to 110 minutes, and there are around 5 to 6 sleep cycles, and predominantly in the first part of sleep, deep sleep predominates, and early in the morning, REM sleep predominates. And like we know that every stage of sleep is important, specifically deep sleep and three sleep, which is the most important part leading to restorative of our daily functions. And we know that REM is predominantly in the morning. So not only it is about the like sleep architecture, everything is important, because data have shown that if a patient is having normal sleep efficiency, but and sleep study is showing a lot of fragmentation and lot of arousal, it is having impact on day-to-day function and daily life functioning. So it is not only about the architecture. There should be proper like cycling architecture should be proper. There should be like N1 of 5 to 8 percent, and N2 should be around 45 to 55%, and N3 and REM, that are the most predominant and most important part, should be around 20 to 25%. So it is about the continuation of sleep, which should be without fragmentation, without micro arousals, and it should be continuous.
Thank you, Dilbag. So the sleep, the proposition, continuity, cyclic pattern, or the so matters for the whether good quality or bad quality sleep. So good quality sleep caters the proposition, mainly the non-REM, 80 to 80%. In that N1, N2, N3 is proper timings, and the REM stages 20 to 25%. So REM cycles once in 90 to 120 minutes. There are 5 to 6 cycles we repeat. So we have to see meticulously in the sleep studies, polysomnography. So as per the things we have to measure and go for the whether normal sleep or abnormal sleep we have done. Thank you, Dilbag. So we'll go to the Dr. Ravi Doshi. The question is sleep architecture differences in male and female. Is there any difference between the male sleeping pattern, female sleeping pattern, or the architecture of the sleep? What's the difference between these two? Gender, any variability?
Well, sir, predominantly in males, we find that there is relatively more of N1, N2 of sleep. And in younger, and they will have a higher arousal index as compared to their same age females. The lighter sleep is more fragmented in males, and we definitely find more OSA in males predominantly till the as compared to the post premenopausal females. So definitely in those OSA individuals, the REM will also be proportionately reduced. In females, we find that there is a decreased sleep onset latency. They tend to go to sleep earlier. They have more slow wave sleep, and relatively older women have a higher duration of REM as compared to other males of the same age group. The this particularly we see that more incidents of insomnia and restless leg syndromes like are seen in females as compared to males, sir. So although there are subtle differences, but in view of the hormonal changes that premenopausal women undergo, there are changes in the sleep architecture which are seen in males and females.
Thank you, Ravi. There is no the men and women physiology of sleep is varies. This is very important in a sleep disorders. Coming to the sleep disorders, so based on the symptomatology, the women presents differently, and men present differently with the symptomatology. So these physiology of sleep in men and women are very important for the diagnosis of the sleep disorders. So thank you. You highlighted very nice, valid points. Thank you. Over to Dr. Deepti, the sleep architecture and efficacy of sleep intervention. So, what is your take on this? Can you throw some light on the sleep architecture and efficacy of sleep intervention?
Yeah, so I think it's been previously discussed. The normal sleep architecture consists of the REM sleep and REM sleep. So the main aim of the sleep intervention to improve the sleep architecture is not only improving the quantity of the sleep, but improving the quality of the sleep. Because poor sleep quality leads to a lot of health issues and causes the cognitive dysfunction, fatigability, irritability, reduction in their work efficiency. So the aim of the sleep intervention is to improve the sleep efficiency, improve the sleep fragmentation, reduce arousal or reduce the sleep fragmentation, very important in the reduction of the VSO, which is wake after sleep onset. So there are multiple interventions. The first intervention, we should always focus on treatment of the underlying cause. Whether it is OSA, USA, lot of fragmented sleep, increase in the N1 but reduction in the N3 in the REM sleep. So improvement of the underlying cause, or otherwise if the sleep is fragmented because of some reasons like restless leg syndrome, pain. So treatment of first underlying cause. Second, after treatment of the underlying cause, then very important role of the sleep hygiene. The sleep hygiene, the timing of the sleep, the environment of the sleep, and avoiding the caffeine. So improvement in the, like, telling them how to have the proper sleep hygiene. Then the cognitive behavioral therapy after that, which is the stimulus control and the sleep restriction, works a lot in the patients who are having disturbed sleep cycle. Now there are many studies are coming about this moderate intensity aerobic exercises for improving the your sleep architecture, which has shown a very positive results with the proper intervention of this exercise, aerobic exercises. Then another, the last option comes even after this is not improving, is the drugs. With the help of some drugs, like we have benzodiazepines, non-benzodiazepine drugs like acid and the melatonin. So these are the interventions which we can do to improve the sleep architecture.
Yes, thank you, Deepti. So nowadays we are all practicing in an era of precision medicine. So precision sleep medicine. So we have to pinpoint the diagnosis. So one size does not fit for all. We have to see each and every patient different. We have to have the personalized treatment, individualized treatment. For that, these kind of intervention based on what kind of sleep architecture. The objective tests are very important apart from the subjective methodology like asking clinical questionnaire and the examination findings. So objective tests like the actigraphy, hypnogram, and the sleep studies are paramount important to teach a diagnosis and intervene accordingly. Whether the patient needs the what kind of treatment exactly, so medical treatment or surgical treatment or intervention, PAP therapy, there will be plenty of things. So thank you. So over to Dr. Dilbagh Singh. So how does circadian rhythm interact with the sleep architecture? So yeah, can you throw some light on the circadian rhythm and the sleep architecture?
Okay, so separated two process. One is the process S, which is homeostatic sleep drive, which is maintained through the adenosine, and one is process C, which is through the suprachiasmatic, that is the master nucleus. And a process is S is responsible for like the, of the deep sleep, and process C is basically responsible for propensity of the REM sleep. So circadian rhythm, it is the one which is the determining timing of REM, core body temperature, and melatonin secretions. And REM peak is early in the morning because circadian REM drive is maximum in the early morning. So we normally see like circadian rhythm disorder like jet lag and like shift worker disorder, advanced sleep wake syndrome, delayed sleep phase syndrome. And what has been shown in studies that those who are like rotational these shift workers, they are more prone to MI, they are more prone to insulin resistance, because in these there is a decrease in sleep, decrease in REM sleep, which predispose to these individual to increase in sympathetic stimulation with increase in the cortisol. So ultimately, circadian rhythm is very important for the sleep architecture, continuation of the sleep process, because it is basically through the adenosine, which is process S and process C.
Thank you. The sleep architecture and circadian rhythm. Mainly, there are two systems. One is a process C and process S. So circadian, this is biological clocks. In a case of a shift worker, they are more prone to get the myocardial infarction because of the lot of chemicals, unwanted chemical release from the brain centers which affect the system. So the circadian rhythm and sleep architecture is a very important link. So we have to carefully see both from the clinical history and the the sleep architecture from the objective methodology like sleep studies and all. Thank you. So, Dr. Ravi, uh, sleep architecture and the sleep disorders. So, what is your take on this? So, what is the relationship between the architecture with the normal or abnormal? So, what is the relationship between the abnormality in the case of sleep disorders, sleep physiology and sleep pathology?
Well, sir, in order to understand sleep disorders, we need to touch upon how we measure several the sleep architecture also. We use our common polysomnography, in which we look at sleep onset latency, REM latency, total sleep time, sleep efficiency. We use hypnogram, which you had so beautifully shown, and actigraphy also. So by the means of these tests, we will analyze the different sleep disorders or a patient presenting with sleep related breathing disorder problems. So suppose we have a patient of OSA and we put that person for a level 1 polysomnography study. We will see that that person will have frequent arousals. There will be a fragmented sleep pattern, that will sleep architecture that we'll be seeing. There will be more of N1 light sleep, less of N3, which is the deep sleep, and the REM overall time will also be reduced. This is the most common sleep disorder that we find. So I spoke about this in a bit detail. The other most common disorder which we find is insomnia. So insomnia, it is so commonly seen while we are doing sleep study. There is a decreased sleep efficiency overall, and particularly patients who are having problems like depression or stress, they will have decreased slow wave sleep, and there will be a decreased time to the first REM sleep. At the same time, you have other disorders like narcolepsy. Narcolepsy, basically, we will diagnose by picking up early sleep onset REM periods. So this again defines the role of sleep architecture. Conditions which are very common like restless leg syndrome, we find that the deep sleep is reduced and light sleep is increased. Parasomnias, which are so difficult to diagnose, yet when they are clinically so relevant, we find predominantly they can either occur in the early or in the N3 part of sleep. People who do substance abuse will have an alteration in their N3 or their REM patterns usually. And the most common symptom which we see in elderly in the form of chronic pain, we see that their sleep depth and efficiency is remarkably reduced. So, sir, in several sleep disorders, we need to measure the sleep architecture with the appropriate test using a proper sleep history and tool.
Thank you, Ravi. The sleep architecture and sleep disorders. So we have to see carefully apart from the clinical history and the sleep stages, whether the N2 is correct in proportion or N3 stage and REM stage. There are various kinds of sleep disorders. The common sleep disorders we come across is insomnia, sleep apnea, and comorbid insomnia and sleep apnea, and the narcolepsy, restless leg syndrome. So these are all things we have to see meticulously the sleep architecture, N1, N2, N3 stages, whether the correct period or not, any the absence of N3 or this shortening of the N2 stages, and whether REM stage is there or not, any latency. We have to see a lot of things matters. So for that, the sleep architecture and the communicate correlate with the sleep disorders is paramount important for the clinicians we diagnose the disease properly. Okay, thank you. So over to Dr. Dipti. The question is the sleep deprivation.
Jairaman, can I just interfere in between?
Please.
Yeah. So, Dr. Ravi, excellent answer. Just I want to highlight one more thing is that whenever we are reading any kind of sleep report, I think we have to make mental note about what all drugs the patient is taking, because sometimes many of our patients, they are on sedatives, and then you will have a disproportionately decreased increased sleep, and there is more of into sleep. Okay, so there are a lot of K complexes and spindles. So always I think we have to tell our technicians also that to mention what all drugs this patient is taking, because sometimes we just get confused because of if the proper histories, for example, drugs like clonidine, and even sometimes even some antihypertensive drugs, even the beta blocker, the steroids. So they all can have decreased, the impact on the sleep architecture. So I think that is one thing which we all have to uh, take into consideration. So
Yes, thank you, Mahavir. Drug history is paramount important. So certain drugs causes the sleep disruptions. So we have to ask the drug history, what are the medications he's taking for any cardiac or any respiratory. So we have to ask the patients thoroughly. Drug history is paramount important. Thank you, Mahavir. So question to Dr. Deepthi, sleep deprivation. So the common thing we are seeing in day-to-day practice, deprived sleep thing, and the sleep intervention. So how to intervene these kind of sleep deprived people, or can you throw some light on the sleep deprivation and the sleep intervention?
Okay. So the sleep deprivation is in simple language when the total sleep time, especially in adults, is reduced less than 7 hours. So and plus whether even if they are having 7 hours sleep, whether they are having proper restorative sleep or the sleep is fragmented. So it's basically the quantity and the quality of the sleep when that is disturbed, the patient is going into the sleep deprivation. Now, there is acute sleep deprivation and there is a chronic sleep deprivation. So, to rule out the cause is very important. So, the acute sleep deprivation generally we see in patients who are doing night duties, who are shift workers, or who are under a lot of stress, and especially who are traveling, taking a long flight, jet lag people. In those, we see a commonly acute sleep deprivation. Then the patient's chronic sleep deprivation, we see underlying some medical issue, like OSA patients, CSA patients. They generally have chronic sleep deprivation because of the fragmented sleep and shift worker sleep disorders. The patients who are having a lot of pain, parasomnia, REM behavior sleep disorder, will see a lot of sleep fragmentation in those category of the patient. We see there is increase in the sleep latency, total sleep time is reduced, N3 sleep is reduced, and the REM sleep is also reduced. Sometimes to rule out the cause in the patients of chronic, we do a polysomnography. So in polysomnography, you will see the sleep latency is markedly reduced. And we see REM rebound phenomena in this category of the patient. So first and foremost, the management of the sleep deprivation is to rule out the cause. What is the cause of the sleep deprivation? So the first and foremost, it starts with the behavioral intervention, teaching the patient about the sleep hygiene and treating the underlying cause why the patient is having sleep deprivation. Then comes the stimulus control and sleep restriction, increasing the nighttime sleep and reducing the daytime sleep, and giving a proper answer to the patient who are shift worker, because the main issue occurs with the shift worker, their shift keeps changing every day or every 2 days. So giving them a proper schedule of their sleep. Then comes the, if not these are not helping, then comes the intervention with the medicine. Like we have benzodiazepines, we have Z drugs like zolpidem, then now this orexin antagonist drugs, which also helps a lot in restoring the sleep. But again, before prescribing any medication, a proper evaluation of the condition is very important.
Yeah, thank you, Deepthi. So quality sleep matters than quantity of sleep. So quality means the good sleep by definition. You go to the bed within 20-30 minutes, you go for the sleep, and continuous uninterrupted sleep. You wake up in the morning, you feel fresh, active. That is no definition of good sleep. Even 5 hours, 6 hours sleep. So this is a good. So quality matters than quantity. The lot of no sleep deprivation, sleep fragmentation we are seeing in a case of worker. So late night workers, there we are seeing a lot of architectural distortion in the sleep pattern. So subjectively we can ask so many things, and objectively also we can measure the poor sleep quality in the wave pattern, etc., etc. So the interventions we have to carry out accordingly. This is an important thing. Okay, thank you. Over to Dr. Dilbag. How does stress or psychological state influences sleep architecture? You all know very well about that. Stress plays a major, no, the culprit behind all the diseases. So, how to what is the influence of this psychological state and in the sleep architecture? Over to Dilbak.
Sir, sleep is basically to the ventrolateral preoptic nucleus through the ascending arousal system, through limbic system, also controlled by the hypothalamic pituitary adrenal axis. And whenever we know there will be stress, there will be increase in corticotropin release hormone, ACTH, cortisol, increase in sympathetic stimulation, and this acute stress will increase the cortisol hormone, which will increase at the norepinephrine level at the locus coeruleus, which is one of the system responsible for awakeness and arousals through mononergic and cholinergic neurons. Second, stress through cortisol will decrease the GABAergic inhibition of the arousal system. And third is the high frequency of EEG in the stress patients. So the changing stress can cause in sleep in this, that it will cause the increase sleep latency, increase in REM sleep, decrease in N3 stage, increase microfragmentation, increase micro arousals, and in long term, the acute stress predisposes the patients to chronic stress, which will ultimately will be leading to increase in the continuous release of the cortisol hormone.
Thank you, Dilbag. So stress plays a major role, which release a lot of chemicals from the brain, like cortisol, acetylcholine, and it induce a good sleep, and cortisol will induce a bad sleep. There are a lot of disruptions. So we have to accordingly, play and do the needful for this patient. Thank you. Over to Dr. Ravi. So sleep, is a dynamic process. Sleep is a bodily rest, and brain-wise, there is a lot of active things is going on. There are so many theories behind the sleep. So, what is your take on this? The sleep and the sleep theories.
Well, sir, sleep, like you told, plays many different functions like physical repair of the body, brain function, energy conservation, making it very important for survival. So we are bound to always postulate what are the theories. Why sleep? Why do we sleep at all? So, like Dr. Dilbag very appropriately told, I would say the two process model of the homeostatic and the circadian, the process S, the process W. So it tells that when one sleeps, it helps to determine how long one sleeps. So that is one very important point you had illustrated in your presentation also. But then, as per the physiological role, several theories have been postulated to why we sleep. It can be restorative, in which there is removal of the waste products, the tau proteins and amyloid, which accumulate in the brain, leading to repair and rejuvenation. Then there is the adaptive or the evolutionary theory for safety and for energizing ourselves, we sleep. Then there is the brain plasticity or cognitive therapy, which says that there is the whole rewiring and memory consolidation process which takes place. There is one more synaptic homeostasis hypothesis, in which again consolidation of the synapses in the brain and deeper memories are emphasized as the main role of sleep. Then there is the energy conservation hypothesis, in which it is told that there is a lot of energy saved in during sleep, which helps in performing all the other vital functions of the body normally. So all of these different sleep theories are postulated, but if given a choice, I would say what Dr. Dilbag told about homeostatic and circadian mechanism, that I feel is the most relevant theory to which we can relate.
Thank you, Ravi. So we'll take some chat box questions. Dr. Ganesh Patni from Madhya Pradesh, Hindu. So what kind of bed should be used by sleep disc patients or disc bulging patients? I think this is the anyone you can take, because the further discussion from every month we are going to take the subject appropriately. So today's topic about mainly the basics of sleep and sleep physiology and sleep architecture, science behind the sleep. Anyway, for the questions they asked from Hindu, Ravi, can you answer this question? What kind of bed should be used by sleep disc patients or disc bulging patients?
Well, basically, sir, these questions will be having a lot of
pain, but a firm bed is advisable, not a very bed in which you will just whether it has to be firm. You shouldn't just go into that. It shouldn't be very fluffy, very soft, and a firm bed with proper positioning as per the side of the bulge which is illustrated. That I feel will be appropriate for that patient.
Good. Thank you, Ravi. One more question from Tenkasi. Is the state of Tamil Nadu. Dr. K. Somasundram is asking about the dreams. Which part are parts of the brain involved? Why it occurs only in some days? Anyone? Dilbag? Dreams, which part are parts of the brain involved? Why it occurs only in some days?
Normally, dreams are occurring, but we are remembering only some part of our dreams. Basically, when we are waking from, I guess, like we are in REM sleep, and sometimes we awake from REM sleep, and some part of dream is like going on, and we basically remember that dream. But this is like normally in REM sleep, dreams are occurring, I guess, daily.
Okay, thank you. Dr. Nataraj from Karnataka, Tumakuru, asked questions about does metophyllin is useful in OSA? So these questions will be discussed in the later part of the webinar. Anyone, you can shortly you can answer. Deepthi or Ravi?
Sir, it is a respiratory stimulant.
So etophylline is having very minimal role in obstructive sleep apnea. Yeah, but especially in patients who are having underlying some airway disease, in them it may be little helpful, but otherwise very minimal role in only OSA patients. There are some theories which says that it can reduce the upper airway collapse and reduce the respiratory drive, but very less role in OSA.
Okay, fine. So one more question from Rajasthan, Jaipur. Role of effect of meditation. Meditation and sleep. Dilbag?
Basically, studies have shown that meditation leads to increase in deep sleep. So definitely there is a role of meditation because it leads to relaxation of mind. There will be decrease in stress hormone. There will be decrease in cortisol, which will ultimately decrease to activation of the sympathetic stimulation, and that's definitely it will increase the deep sleep in those patients who are doing yoga, nidra, and other things for meditation. They are and sleep studies have been done for those patients, and those patients are having a major part of like deep sleep in maximum part. So the meditation lead to relaxation of mind, leading to decrease in stress hormone, leading to more deep sleep.
Yeah, I fully agree. So effect of meditation helps in producing a good sleep. There is no doubt. Yoga nidra, a lot of techniques, relaxation techniques, which leads to good sleep. Yes, thank you, Deepan Bilba. And the more question from Dr. Kesari Rahul from Telangana, Hyderabad. Is diabetes hypothyroid associated with sleep apnea?
It is definitely associated diabetes. So we say whether the chicken or egg with the metabolic disorder, whether the diabetes or the sleep apnea or the sleep apnea or the diabetes. So they are correlated with each other because lot of inflammatory process also occurs because of the sleep apnea, and diabetes also leads to sleep apnea. So it's like they both are like correlated. If sleep apnea, so many times you will get a referral from the referrals like uncontrolled diabetes, insulin resistant patients you will get from endocrinologist. The patient is having this and then they are referred. So yes, there is definitely correlation between metabolic disorder and OSA.
Yeah, there is a strong relation between the metabolic syndrome X. There is 4 components you all know very well: diabetes, hypertension, dyslipidemia, and obesity. Plus OSA, we call it a syndrome Z. There is a strong association between these two. Any hormonal wise, this hypothyroidism plays a major role, major link with the OSA. There is no doubt at all. Okay. One more question from Dr. Gauri Sankar Krishna from Andhra Pradesh. Role of metformin in sleep induction. All the discussed question. Anyone, Ravi?
Sir, Sir, mostly it's used in diabetes. It is not primarily used for sleep induction, but it's the neural absorption of glucose. It is somewhat potentiated. So it says that it helps in improving sleep metrics, but it is not an official indication. Definitely, there is a role that it benefits sleep inductions.
Yeah. Metformin has a plethora of role. There is, but I don't know exactly what sleep induction. Anyway, so one more question from Dr. Kalaikovan from Tamil Nadu, Kadalur. What would be the advice for night shift workers to preserve the sleep architecture? Tips to nighttime workers, yeah, shift workers. Deepti?
So yeah, so shift workers are very difficult patients to manage. So why? Because they have every shift. So it's the first time the history taking is very important. Ki how many, like in how many days their shift changes. Like it's like every day their shift is changing. It is 2 days or per week. If they are having a lot of issue with like frequent change of the shift, so it is better to tell them to speak to the place where they are working, to give them at least long duration of one sleep cycle. Like if the night shift, it should be at least for a week, so they have some time to again shift their sleep when they are having the daytime shift. So yeah, it's about always guiding them how to shift their sleep, because in one night they cannot shift their sleep. So you have to tell them ki, like by every 2 hours now you have to start shifting your sleep as your shift is going to change. This is my
Okay,
take on this.
thank you. So, question from Dr. Gauri Singh from Andhra Pradesh. For my patient, whatever he speaks in the dream of sleep, that will come out as a nightmare. So, what is the treatment plan? Speaks in the dream of sleep that will come out as a nightmare. What is the treatment plan? This all questions comes from the parasomnias. So definitely we'll take all the discussions in future meetings. There is definitely, so anyone can answer shortly. There is no major things at all. Dilbag or Ravi?
We need to differentiate whether it is nightmares or REM sleep parasomnias. So a detailed history is important in such cases, and sometimes polysomnography is needed to rule out REM parasomnias. And as per like if it is nightmare or night terrors, we need to treat accordingly. And in REM parasomnias, we mostly sometimes need melatonin and zeal group of drugs for the like sleep induction and maintenance.
Even the benzodiazepines, I think they help a lot in parasomnias and RBDs.
Clonazepam, I think it is having.
Clonazepam.
Yeah, these are all parasomnias. We'll take the discussions later part of future meetings. So now the question to Dr. Deepti. Can you throw some light on? Already we discussed once again for the late joiners, actigraphy and hypnogram. So
Okay.
can you tell something about the actigraphy and hypnogram? So we are seeing a lot of watches wearing and seeing the sleep pattern, SpO2, oxygen, everything. So is it what is your take on this kind of guidance?
So actigraphy is totally different from the, like we are talking about the another watches which they wear for the sleep cycle. So actigraphy is basically, it is a non-invasive objective tool to assess the sleep pattern, whether the patient is awake or going or sleeping. So that detects the sleep on the motion basis. If the patient is moving, it means it will detect the patient is awake. If the patient is lying down with no activity, it means the patient is sleeping. But it does not give you about the stages of the sleep and whether the patient is having any sleep disorder. So that is totally different from the other watches, other wearable devices which we are comparing. So it is just giving you about the duration of the sleep, total sleep time, sleep latency of every day. Mainly recommended in the patients who are having hypersomnia, insomnia, or circadian rhythm sleep disorder, or irregular sleep pattern, or delayed sleep phase disorder. In this category of the patient, we give them actigraphy. Hypnogram is totally different from the actigraphy. Hypnogram is generally graphical presentation of the sleep, which we generally get with the polysomnography, where your sleep stages is plotted against your duration of the sleep, which will typically give you the N1, N2, N3, and the REM sleep, the total your sleep cycle which happened throughout the night. So basically, actigraphy is an objective tool for assessing your sleep, total sleep time in a day, and hypnogram is a visual representation of your sleep cycle throughout the night.
Thank you, Dipti, for good definition about actigraphy. Actigraphy is subjective tool to measure the sleep. So hypnogram is cycle of sleep we can measure by sleep studies in the polysomnography or polygraphy. Thank you. So over to Dr. Dilbag Singh. Is reduced REM sleep REM pattern or N3? Is it always pathological or can sometimes be adaptive? REM and N3 absence or reduced REM or N3. So what is your take on this?
Sleep is basically process. And normal we see like in aging there is reduction in N3 sleep, there is reduction in REM sleep, there is increase in sleep latency, there are more arousals, more sleep fragmentation, sleep is poor quality. And like we see in sleep deprivation, there is REM rebound and deep sleep rebound. The N3 rebound is initial, then the REM rebound. So sometimes sleep deprivation can lead to changes which are like physiological, but if it is chronic and it is persistent and if it is causing sleep fragmentation associated with daytime symptom, then it becomes pathological. And also it's altered, like sleep architecture is altered by various drugs like SSRI, SNRI, TCAs. All these decrease the REM stage of the sleep.
Okay, thank you. So one more questions from Tamil Nadu. Dr. Rajeshwari Narayanaswamy is asking, what is the cause of bedwetting in adults? Nocturnal enuresis in adult patient. This comes under the parasomnias. Ravi, what's your take on this? Yeah. What is the cause for bedwetting in adults?
Sir, can't say that it is exclusively sleep related, but yeah, it is a parasomnia like you told, and it can be related to the loss of sphincter control, which is seen in several phases of sleep like REM.
Yeah, thank you. One question from Tamil Nadu, Dr. Khalid Kovan. Sudden abstinence of alcohol in sleep physiology, your expert inputs.
Sudden abstinence. Sir, basically, alcohol has a lot of effect on the sleep architecture. It causes more of light sleep and the deeper sleep decreases, and there is a lot of rebound phenomena which happens. So chronic alcoholics, when they leave sleep, there is a lot of REM and deep sleep deficit which is bound to happen. But initially, there will be a lot of poor sleep which will happen, more arousability. So I feel acute alcohol abstinence might definitely lead to more of irritability and more fragmented sleeps.
Yeah, thank you. Right. A question from Dr. Irshad from Kerala. Some people feel fresh after small amounts of sleep, but some feels very sleepy after even long periods of sleep, even without OSA. So what is the physiology behind? May I ask the respected panelist? Quantity of sleep and the sleepiness.
Yeah. So,
Yeah, Diti.
okay. So the quantity of the sleep, so there is like phenomena micro sleep and the macro sleep. So again, whenever you are assessing a patient of sleep, what is my note that taking proper history of the patient is very important. What is the sleep cycle of the patient, whether this patient has taken proper nighttime sleep or not, and then they are taking the daytime sleep. Because some patients, they have not slept well at the night, then they are taking a daytime nap. So even after waking up after 1 hour, they will not feel fresh. So always take a proper history. Plus second comes a medication history, whether they are on some medication or not, which is causing excessive sleepiness or which is causing which is like causing this sleep. Some patients, yeah, may feel, we say as like now this in Japan we say they are developing this sleeping pods for the daytime nap, because there comes a point after the lunch where they need a short nap. So yeah, so it very important from which stage they are getting up. If they are getting up from the REM sleep, yes, they will be very sleepy, they will feel very groggy and all. But if they are continuing or they are waking up from the N1 or the N2 sleep, they will feel fresh, they will not be that sleepy or the groggy. So first and foremost, the sleep history is very important to ask in these patients.
Thank you. So, clinical questionnaire, apart from the history and the examinations, are paramount important. Then finally, we have to objectively, by doing the test, to confirm so what kind of sleep disorders, whether quality sleep or quantity sleep. So, where is the deficiency? After thorough investigation, so we can pinpoint the sleep disorders and treat accordingly to prevent unnecessary morbidity and mortality. Thank you very much for wonderful answers. So I request each and every panelist, you can give some, so online or 1 minute take-home messages about the science behind the sleep, sleep architecture, the basis, the physiology of sleep. Can you throw some light on basic one-liner take-home messages? Start from Dr. Ravi Doshi.
Well, sir, I would just like to say that sleep medicine is a very important subject, and its principles are based on sleep architecture. So whenever we start reading a sleep report, we should always try to keep the normal sleep architecture in mind. It will make us very quick in picking up the abnormalities. They appear very gross and obvious at that time.
Well said, Ravi. Well said. Yeah. Normal sleep architecture is very, very important when you see the pathology of the sleep disorders. Thank you. Dr. Deepti, you will take a message.
Yeah, so I agree with Dr. Ravi. So whenever you start, sleep architecture only gives you a lot of answer about the sleep disorder. Whenever you're seeing a sleep study report, so proper understanding of the sleep architecture and starting your reports after first seeing the sleep architecture, you should always go in that way. First with the EEG pattern, and then you should come down to the respiratory pattern. So always start with first your sleep architecture, and then you go ahead with your polysomnography report.
Thank you. Over to Dr. Dilbagh Singh, your one-liner, take a message or final wordings from the basic physiology of sleep.
As I said, it is due to the interaction between various neurobiochemical, physiological, and other alteration. And sleep architecture is very important per se, because the staging of sleep is very important. N1, N2, N3, REM sleep, and sleep cycling is very important. And sleep should be continuous without fragmentation, and like it should be without any arousal. Sleep efficiency should be more than 90%, and we should see the report properly to say that the patient is having proper sleep efficiency. And last but not the least thing, that there is excellent webinar and very nice initiative, and want such webinars more, because discussion is like going and going on for last around 1.5 hours. And thank you so much for this wonderful opportunity.
Thank you, Dilbagh, and thank you, Deepti. Thank you, Ravi Doshi, for the wonderful discussions about the science behind the sleep and the sleep architecture and physiology of sleep. So sleep is an paramount important. It's not a luxury, it's a very, very essential thing for the life, like respiration, excretion, reproduction. Sleep is a paramount important. Sleep is a medicine, sleep medicine. So sleep is one of the pillars of health, like diet, exercise, and sleep. So among all the three, sleep is a paramount important. So that's a very important thing. But in our places, sleep and sleep disorders are very, very under-recognized, under-diagnosed, under-treated conditions. So we need to have create awareness. For that, so we have a wonderful association, Southeast Asian Academy of Sleep Medicine. So we have to fight against all kinds of sleep disorders. So for that, every month we are planning to conduct the webinars. Various topics start with today's physiology, and a lot of topics we can discuss. I thank you, SEAASM, for the wonderful platform to disseminate the knowledge about the sleep and the sleep promotional aspect. I thank you, our current president, Dr. Mahavir Modi, and the patron, Dr. Sunakar, and the dynamic secretary, Dr. Shivani Swami. I thank you all the delegates. Thank you very much for wonderful participation. So every month we'll meet, we'll stay tuned, we'll update all the things. So with that, I conclude my talk. Thank you very much. Long live SEAASM. Over to the dynamic secretary of Southeast Asian Academy of Sleep Medicine, Dr. Shivani Swami.
Esteemed colleagues, distinguished speakers and panelists and participants of the first webinar of the SEAASM. As we have reached the conclusion of our first inaugural webinar on the fundamentals of sleep, this session has provided a comprehensive overview of sleep's critical role in respiratory health, cognitive performance, and identification of prevalent disorders such as OSA. The insights shared today have extensively talked about sleep's essential contribution to overall health and disease presentation. We extend our sincere gratitude to the expert speakers for their presentations, to our partner Cipla for their invaluable support, and to our dedicated organizing team, to the technical team for ensuring flawless execution. I would also like to extend a heartfelt thanks to my mentors, Dr. Himanshu Garg and Dr. Rajesh Vangar, and to the President of SEAASM, Dr. Mahavir Modi. And last but not the least, Dr. Sami Jayaraman, who's the treasurer of CSM. Nikita, who has tirelessly worked every day and night for the CSM webinars, is somebody that we can never thank enough. Your engagement in this session has enriched the discourse immensely. We look forward to your continued participation in all our forthcoming webinars, which will address advanced diagnostics and therapeutic strategies and newer advances as well. Thank you once again. CSM remains committed to elevating sleep medicine in the country. With that, we wish you all a very good night. Thank you.